Good afternoon, everyone. My paper on nasal transposition of split lateral rectus muscle with medial rectus resection in third nerve palsy. As we all know that third nerve palsy is very difficult strabismus to manage surgically. Surgical management options include lateral rectus deactivation or vital fixation of medial rectus, superior oblique transposition at medial rectus muscle, and LR muscle transposition supranasal. The Kaufman has first described the isolating and splitting the lateral rectus muscle and transposing the superior and inferior halves to a retroequatorial location for the management of third nerve palsy. Later, Gokigit et al. Suggested modification of this technique by transposing the superior and inferior halves of the split LR muscle 2 mm posterior to the superior and inferior border of the MR muscles. The purpose of our study is to evaluate the post-operative ocular alignment in patients who underwent for nasal transposition of split lateral rectus muscles for third nerve palsy. A retrospective review of the medical record of patients treated for third nerve palsy with nasal transposition of split LR was performed after institutional review board approval. Informed written consent was taken from the patient to use their photographs. The initial and final ocular alignment, post-operative ocular motility, and complication were noted. Surgical success was defined as post-operative alignment within 10 prism diopter of orthotropia in primary position by Krimsky test. The surgical technique what we have followed, radial conjunctival incision was placed in all 4 quadrants of the operative eye. The LR muscle was isolated and separated from the attachments to the surrounding tendons, pulleys, and inferior oblique muscles. The upper and lower half of LR muscle was secured at the insertion with 2 separate double-armed Becquerel sutures, and the muscle was then detached and split in half longitudinally as much posterior as possible. And muscle hook was placed within the superior nasal conjunctival incision and passed laterally under the superior oblique and superior rectus muscle, and the upper LR suture was passed through the opening in the gas hook, and hook was retracted to transpose the suture at the superior pole of the MR muscles. Similarly, the inferior oblique muscle was exposed and through the inferotemporal conjunctival incision, and the upper half of the lower half of the LR muscle was passed through the inferior oblique and inferior rectus muscle, and this was transferred at the lower pole of the medial rectus muscles. And MR muscle was also resected about 6.5 mm in each cases. The total 4 patients, 2 male and 2 female, were included in our study. Only in 3 patients desired procedure was successfully completed. Mean preoperative deviation was 85 PD exotropia. All 3 patients were within 5 PD of orthotropia postoperatively. Eye movement were limited in all patients postoperatively, and no other complication was noted in our series. The procedure not completed in 1 case because of extensive fibrosis of LR muscles, which prevented splitting and transposition beyond the temporal aspects of the vertical rectus muscle. A successful outcome was achieved in all 3 patients in whom the procedure was completed. Average follow-up was 8.3 months, and the 1 patient had preoperative vertical misalignment that was not resolved with the surgery. This is the case detail in the age group 21 years. The first patient is 90 PDXT, this was the case of 90 PDXT, which was ortho post-operatively. However, the movements were restricted. This was the same patients in the primary position. This was the second patient in which the patient has large angle exotropia with the hypo. The exotropia is resolved with the surgery, but the hypo, 5 PD hypo was present post-operatively. This was another case of the complete third nerve palsy. The child is ortho post-operatively. So in discussion, the nasal transposition of the LR muscle to treat strabismus due to third nerve palsy was first described by Taylor as a transposition of the entire muscle to the superior nasal globe. The procedure reduced his patient exotropia by 40 to 50 prism diopter. Kaufman addressed potential problems with induced torsion and vertical deviation by splitting the LR muscle and transposing the superior and inferior halves to a region 20 mm posterior to the limbus and posterior to the superior and inferior nasal vortex vein. In an effort to obtain further reduction of the horizontal deviation, Gokigit modified this technique, bringing the superior and inferior halves of the LR muscle anterior to the vortex vein and approximately 2 mm from superior and inferior edge of the MR muscles. Their innovation of placing the muscle halves pre-equatorial greatly improved the effectiveness of this concept. In our technique, we have combined this technique with subsequent MR strengthening procedure, suggesting that this is more likely to give long-term benefit because of mechanical forces by the resecting the MR muscles, as well as there is no opposing forces from the LR. So to conclude, the nasal transposition of the split LR muscle for treatment of strabismus associated with third nerve palsy offer excellent horizontal alignment in primary position. We advise caution when considering the procedure for patients with extreme LR muscle contracture. It's better to abandon this procedure in that cases. Thank you.
Procedure has already been described. Yes, well known.
Yes, sir.
So, how should I mark your originality for your paper?
Sir,
He has done it for the first time, sir.
First time.
It is there in the literature. He is presenting his own data, sir. You mark as you want to mark.
No, I'm just joking. See, they've asked us mark the paper based on the originality. So I asked you a question. Has it been described? Okay, never mind. Well done.
sir.
These are all very difficult, sir. Congratulations.
Thank
Did you cut the infraoblique and supraoblique also, tenotomy or myectomy?
No, sir.
You did not do it.
No,
Lucky for you, you got away with it without having any choroidal effusion or anything.
No, in all three cases there is no
There was
choroidal
no
effusion.
choroidal effusion. Yes.
Okay.